Good afternoon. I'm Commander Ibad Khan, and I'm representing the Clinician Outreach and Communication Activity, COCA, with the Emergency Risk Communication Branch at the Centers for Disease Control and Prevention. I'd like to welcome you to today's COCA call. COVID-19 vaccines, update on allergic reactions, contraindications, and precautions. Continuing education is not offered for this COCA call. All participants joining us today are in listen-only mode. After the presentations, there will be a Q&A session. Using the webinar system, you may submit a question at any time by clicking the Q&A button at the bottom of your screen, typing your question in the Q&A box, and submitting your question. The video recording of this COCA call will be posted on COCA's webpage and available to view on demand a few hours after the call ends. If you're a patient, please refer your questions to your healthcare provider. For those who may have media questions, please contact CDC Media Relations at 404-639-3286 or send an email to media@cdc.gov. I would now like to introduce our presenters for today's COCA call. Our first presenter is Captain Tom Shimabukuro. Captain Shimabukuro is a medical officer and currently serves as the vaccine safety team lead for CDC's COVID-19 response. Our second presenter is Commander Sarah Mbe. Commander Mbe is a medical officer in the clinical guidelines team for CDC's COVID-19 response. Captain Shimabukuro, please proceed.
Thank you. Just want to make sure you can hear me before I start.
Yes, Captain.
Great. Good afternoon, and thanks for having me today. It's a pleasure to present to the group. I'm going to be talking about anaphylaxis following messenger RNA COVID-19 vaccination. I just want to note that some of the slides I'll be presenting today are adapted from a presentation at ACIP on December 19th by Dr. Tom Clark. Next slide. So the first concern for anaphylaxis following COVID-19 vaccination occurred in the United Kingdom, which initiated their vaccination program just prior to the US initiating its vaccination program. And on December 8th, the UK started vaccinating with the Pfizer-BioNTech COVID-19 vaccine. On December 9th, the UK authorities confirmed 2 cases of anaphylaxis after vaccination and promptly issued this press release from the MHRA. Based confirmation of guidance to vaccination centers on managing allergic reactions following COVID-19 vaccination with the Pfizer-BioNTech vaccine. Next slide. So as far as the US program, ACIP considered anaphylaxis risk during deliberations on the Pfizer-BioNTech COVID-19 vaccine during its December 11th and 12th meeting. It issued interim recommendations for the use of the Pfizer-BioNTech COVID-19 vaccine, and shortly thereafter, CDC issued interim considerations preparing for the potential management of anaphylaxis at COVID-19 vaccination sites. Next slide. So at an ACIP meeting on December 19th and 20th, CDC gave an update on anaphylaxis in the US following COVID-19 vaccination. And in this presentation, CDC reported identifying 6 case reports of anaphylaxis following the Pfizer-BioNTech vaccine that met the Brighton collaboration criteria for anaphylaxis. All the cases occurred within the recommended observation window and were promptly treated. And all these suspected cases were notified through VAERS or through a CDC notification processes. And at that time, December 19th, 272,000 doses of the Pfizer-BioNTech COVID-19 vaccine had been administered. Currently, there's over 2 million doses of the Pfizer vaccine that have been administered. Next slide. So CDC actions to address these reports of anaphylaxis include close coordination with FDA on safety monitoring and continued enhanced monitoring for anaphylaxis cases through the Vaccine Adverse Event Reporting System. This involves rapid identification and follow-up on suspected anaphylaxis cases, and also case reviews and consultation with allergy immunology experts to provide guidance on evaluation of persons following anaphylaxis to COVID-19 vaccine. And I will say, since the December 19th presentation, CDC and FDA through monitoring and VAERS have continued to identify additional cases of anaphylaxis occurring following the Pfizer-BioNTech vaccination. Next slide. So I want to emphasize the role of healthcare providers in safety monitoring, specifically for monitoring for anaphylaxis. And that primarily involves recognizing, responding, and reporting anaphylaxis cases following COVID-19 vaccination to VAERS, and reporting adverse events to VAERS in accordance with the FDA emergency use authorization reporting requirements and CDC guidance. I'll also mention participation in CDC's VSafe program, both for yourself when you get vaccinated and encouraging patients to participate in VSafe. And finally, communicating with patients on vaccine safety. Next slide. So VAERS is the nation's early warning system for vaccine safety, provides the quickest information on adverse events and the quickest information to allow us to characterize the safety profile of newly authorized vaccines when they're recommended in the population. It's co-managed by CDC and FDA. It's a spontaneous reporting or passive surveillance system, and it depends on individuals to send reports to VAERS. So anyone can send a report to VAERS, but healthcare provider reports are particularly valuable because we believe that the level of detail in the clinical information provided from healthcare providers in these reports is particularly useful for CDC and FDA. Next slide. The process for reporting adverse events to VAERS is an online process. You go to the VAERS website at vaers.hhs.gov, and on the landing page you see here, there is a link in the left-hand corner. You click on that link and it takes you to the electronic or the online reporting form, and you can fill out a report, click submit, and then you get a notification that you have successfully completed a report. For help, there's a 1-800 number, and there's also an information email. And if you want to watch video instructions on submitting VAERS reports, you can go to that YouTube link and view a video that's been created by CDC and FDA. Next slide. And I had mentioned VSafe previously. I just want to mention it again. VSafe is a active monitoring system that was stood up by CDC just for COVID-19 vaccination, and these are some resources on the program. Next slide. Right now, VSafe involves a manual registration process. Patients have to self-register. What I've shown you here on the right-hand side is a screenshot of the VSafe information sheet. The full sheet has a URL code and a URL and a QR code that you can scan to take you to the registration site. Patients have to enter a few data elements and register. And once you're in the system, then CDC begins sending text messages that involve health check-ins. And these messages have links to web surveys where individuals can report on their post-vaccination experience. And we are asking that healthcare providers help us get as many people to use VSafe as possible. And that primarily involves giving a one-page information sheet to patients at the time of vaccination, or posting information in the clinic area, the area where individuals are getting vaccination, posting that so individuals have access to the URL code and the URL and the scannable QR code. And also counseling patients on the importance of enrolling in VSafe. This just can be very quick and saying this is what the program is, and we encourage you to participate. So we've created this electronic version of the VSafe information sheet, as well as some promotional materials for distribution to public health and healthcare partners. Next slide. And I just want to wrap up with a reference slide here on information on how to report to VAERS. The most important thing that healthcare providers can do, both to help us monitor for anaphylaxis and allergic reactions and to help us monitor vaccine safety in general, is to report adverse events to VAERS and report them as quickly after they happen as possible, and to be as complete on the VAERS report as possible. And then it has some VSafe resources and some general CDC vaccine safety information. Next slide. Thank you.
Thank you, Dr. Shimabukuro. So this is Dr. Sarah Mbei. I am now going to go through updates to CDC's guidance around contraindications and precautions to mRNA COVID-19 vaccines. So although the investigation into these reports is ongoing, persons with a history of an immediate allergic reaction of any severity to a previous dose of an mRNA COVID-19 vaccine or any of its components might be at greater risk for anaphylaxis upon re-exposure to either of the currently authorized vaccines. Thus, CDC has updated its guidance around contraindications and precautions to mRNA COVID-19 vaccination. This guidance was developed in consultation with external experts in allergy, immunology, and vaccine safety from CDC's Clinical Immunization Safety Assessment Project, as well as the American Academy of Allergy, Asthma, and Immunology. Next slide. These updated recommendations are included in CDC's Interim Clinical Considerations for use of mRNA COVID-19 vaccines currently authorized in the United States, which can be accessed in the link in the bottom of the slides. And I will mention that the updated version will be going live right after this call. So the current version in the link now it will be updated by about 3 o'clock. These updated recommendations apply to both Pfizer-BioNTech and Moderna COVID-19 vaccines. This interim guidance may change as further information becomes available. And for the purposes of this guidance, an immediate allergic reaction to a vaccine or medication is defined as any hypersensitivity-related signs or symptoms such as urticaria, angioedema, respiratory distress such as wheezing or stridor, or anaphylaxis that occurs within 4 hours following administration. Next slide. CDC considers a history of the following to be a contraindication to vaccination with both the Pfizer-BioNTech and Moderna COVID-19 vaccines. A severe allergic reaction such as anaphylaxis after a previous dose of an mRNA COVID-19 vaccine or any of its components, an immediate allergic reaction of any severity to a previous dose of an mRNA COVID-19 vaccine or any of its components, including polyethylene glycol or PEG, and immediate allergic reaction of any severity to polysorbate due to the potential cross-reactive hypersensitivity between the vaccine ingredient PEG and polysorbate. Persons with an immediate allergic reaction to the first dose of an mRNA COVID-19 vaccine should not receive additional doses of either of the mRNA COVID-19 vaccines because the two authorized vaccines contain ingredients in common. And I will also mention that these persons should not receive mRNA COVID-19 vaccination at this time unless they have been evaluated by an allergist immunologist and it is determined that the person can safely receive the vaccine, such as vaccination under observation or in a setting with advanced medical care available. Next slide. So let's review the ingredients that are included in these vaccines. Both vaccines consist of nucleoside modified mRNA encoding the viral spike glycoprotein of SARS-CoV-2. In addition, both contain 4 different lipids, some of which are in common between the two vaccines, as well as salts, sugars, and buffers. Next slide. And I just wanted to highlight that polyethylene glycol or PEG is a component of both vaccines. Next slide. PEG is a primary ingredient in osmotic laxatives and oral bowel preparations for colonoscopy procedures and is an inactive ingredient or excipient in many medications and is used in a process called pegylation to improve the therapeutic activity of some medications, including certain chemotherapeutics. Additionally, as I mentioned before, cross-reactive hypersensitivity between PEG and polysorbates, which are included as an excipient in some vaccines and other therapeutic agents, can occur. Resources for determining whether a medication contains PEG, a PEG derivative, or polysorbate are included in the footnote on this slide. Next slide. As mentioned, persons with an immediate allergic reaction to the first dose of an mRNA COVID-19 vaccine should not receive additional doses of either of the mRNA COVID-19 vaccines. Thus, it is important for providers to determine whether reactions reported following vaccination are consistent with immediate allergic reactions, which would indicate a contraindication to additional vaccine doses, versus other types of reactions commonly observed following vaccination, such as a vasovagal reaction or post-vaccination side effects, which are not contraindications to the second dose. The following table of signs and symptoms is meant to serve as a resource for clinicians, but may not be exhaustive, and patients may not have all signs or symptoms. Providers should use their clinical judgment when assessing patients to determine the diagnosis and management. I will go through each of these categories in the next slides. Next slide. First, I'll start with immediate allergic reactions, including anaphylaxis. Most immediate allergic reactions occur within 15 to 30 minutes of vaccination, though some may be delayed. Patients with anaphylaxis may report feelings of impending doom, and approximately 90% of patients present with skin findings, such as pruritus, urticaria, flushing, or angioedema, which can be helpful in distinguishing allergic from other reactions. Patients may also have confusion, disorientation, dizziness, lightheadedness, weakness, or loss of consciousness. They may also experience respiratory symptoms such as shortness of breath, wheezing, bronchospasm, stridor, and hypoxia. And patients may have gastrointestinal symptoms such as nausea, vomiting, abdominal cramps, or diarrhea. These persons should not receive a second dose of an mRNA COVID-19 vaccine at this time. We will get into this into later slides, but anaphylaxis is a medical emergency that requires prompt treatment with epinephrine. Next slide. In terms of vasovagal reactions, most occur within 15 minutes of vaccination. Patients may report feeling warm or cold, have pallor, diaphoresis, clammy skin, or a sensation of facial warmth. They may also have dizziness, lightheadedness, syncope, often after some prodromal symptoms, weakness, changes in vision, or changes in hearing. They may have an elevated respiratory rate, especially if symptoms are accompanied by anxiety, and they may have hypotension or bradycardia during a syncopal event. They may also have nausea or vomiting. Persons with a vasovagal reaction to the first dose should receive the second dose, but providers should take appropriate measures in these patients to prevent injuries if a patient becomes weak or dizzy or loses consciousness. Patients should be seated or lying down during vaccination. And we will get into this in later slides, but these persons will be monitored for 15 minutes after vaccination, which will help decrease the risk of injury should they faint. Next slide. Finally, I'll go through vaccine side effects, both local and systemic. So local and systemic side effects following vaccination are common and expected, and most patients will have them. Onset of these symptoms occur a median of 1 to 3 days after vaccination, with most occurring the day after vaccination, which helps to distinguish these reactions from allergic and vasovagal reactions, which have rapid onset following vaccination. Vaccinated persons may develop fever, chills, or fatigue, as well as pain, erythema, or swelling at the injection site, and lymphadenopathy. They may also develop a headache. Vomiting and diarrhea may occur, but not very frequently. In addition, vaccinated persons may develop myalgias and arthralgias. These symptoms generally resolve within 1 to 2 days of onset. Persons with local or systemic side effects following the first dose should receive the second dose. They can be counseled to take acetaminophen or nonsteroidal anti-inflammatory drugs in the event that symptoms develop after vaccination. Next slide. Next, I'll review precautions to mRNA COVID-19 vaccines. CDC considers a history of any immediate allergic reaction to any other vaccine or injectable therapy, that is intramuscular, intravenous, or subcutaneous vaccines or therapies not related to a component of mRNA COVID-19 vaccines or polysorbate, as a precaution but not a contraindication to vaccination for both the Pfizer-BioNTech and Moderna COVID-19 vaccines. These persons should be counseled about the unknown risks of developing a severe allergic reaction and balance these risks against the benefits of vaccination. Deferral of vaccination and/or consultation with an allergist immunologist may be considered until further information on the risk of anaphylaxis is available. Next slide. The following considerations can be used to help the provider conduct a risk assessment for mRNA COVID-19 vaccination in these individuals. The risk of exposure to SARS-CoV-2, for example, because of residence in a congregate setting such as a long-term care facility or occupation, risk of severe disease or death due to COVID-19 because of age or underlying medical conditions, whether the patient has previously been infected with SARS-CoV-2, and if so, how long ago. And of note, vaccination is recommended for persons with a history of COVID-19. However, because reinfection is uncommon in the 90 days following infection, persons with a precaution to vaccination and recent SARS-CoV-2 infection may choose to defer vaccination until further information is known about the risk of anaphylaxis following vaccination. The unknown risk of anaphylaxis following mRNA COVID-19 vaccination in a person with a history of an immediate allergic reaction to other vaccines or injectable therapies. And finally, the ability of the patient to be vaccinated in a setting where appropriate medical care is immediately available for anaphylaxis. Next slide. Allergic reactions, including severe allergic reactions that are not related to vaccines, injectable therapies, components of mRNA COVID-19 vaccines, or polysorbates, such as food, pet, venom, or environmental allergies, or allergies to medications, including the oral equivalents of injectable medications, are not a contraindication or precaution to vaccination with either mRNA COVID-19 vaccine. The vial stoppers of these mRNA vaccines are not made with natural rubber latex, and there is no contraindication or precaution to vaccination for persons with a latex allergy. In addition, as the mRNA COVID-19 vaccines do not contain eggs or gelatin, persons with allergies to these substances do not have a contraindication or precaution to vaccination. Next slide. CDC recommends that vaccine providers observe all persons after vaccination, regardless of allergic history. Those with a precaution to vaccination or a history of anaphylaxis due to any cause should be observed for 30 minutes. All other persons should be observed for at least 15 minutes after vaccination to monitor for the occurrence of immediate adverse reactions. Next slide. To put it all together, there are three categories of persons with a history of allergic reactions that may present for mRNA COVID-19 vaccination. Those that may proceed with vaccination are included in the green box. These are persons with a history of allergies that are unrelated to a component of an mRNA COVID-19 vaccine, other vaccines, or injectable therapies. Persons with these allergies who have a history of anaphylaxis due to any cause should be observed for 30 minutes, and all other persons should be observed for 15 minutes. Persons with a history of any immediate allergic reaction to vaccines or injectable therapies, except those related to a component of an mRNA COVID-19 vaccine or polysorbate, have a precaution to vaccination, shown in the yellow box. A risk assessment should be conducted in these persons. Deferral of vaccination and/or a referral to an allergist immunologist may be considered. If these persons are vaccinated, they should be observed for 30 minutes. In the red box are those persons in whom vaccination is contraindicated. This includes persons with a history of severe allergic reaction after a previous dose of an mRNA COVID-19 vaccine or any of its components, an immediate allergic reaction of any severity to a previous dose of an mRNA COVID-19 vaccine or any of its components, or an immediate allergic reaction of any severity to polysorbate. These persons should not receive mRNA COVID-19 vaccination at this time unless they have been evaluated by an allergist immunologist and it is determined that the person can safely receive the vaccine, for example, under observation or in a setting with advanced medical care available. Next slide. CDC has developed additional tools that providers can use at the vaccination site to help identify persons with contraindications or precautions to vaccination, including a pre-vaccination checklist and further additional information in the form of a fact sheet. Next slide. CDC has also developed interim considerations for preparing for the potential management of anaphylaxis at COVID-19 vaccination sites. These considerations include information on early recognition of anaphylaxis, medications and supplies needed for the assessment and management of anaphylaxis, how to manage anaphylaxis at the vaccination site, patient counseling, and reporting of anaphylaxis. Next slide. The key take-home messages from these guidance are early recognition of anaphylaxis symptoms, prompt treatment with epinephrine, and activation of emergency medical services. Next slide. COVID-19 vaccines will likely be administered in a wide variety of clinical settings, including hospitals, long-term care facilities, outpatient medical offices, pharmacies, mass vaccination sites, and curbside or drive-through sites. These settings differ in terms of usual on-hand human and material resources to manage anaphylaxis. In our guidance, we've included a list of medication and supplies that are important for evaluating and managing anaphylaxis and are recommended for COVID-19 vaccination sites. We've divided them into supplies that should be available at all sites as the minimum requirements to assess and manage anaphylaxis, as well as other medications and supplies that are helpful to include where feasible. All sites should have epinephrine and H1 antihistamines, a blood pressure cuff, stethoscope, and a timing device to assess pulse. Next slide. Finally, the Clinical Immunization Safety Assessment COVID-Vax project is an additional resource. Healthcare personnel or health departments in the United States can request a consultation for a complex COVID-19 vaccine safety question about an individual patient residing in the United States that is not readily addressed by CDC guidance. Information on how to request a consultation can be found at the link below. And that concludes my portion of the talk. Thank you.
Presenters, thank you so much for providing our audience with such critical information. We will now go into our Q&A session. Please remember you may submit questions to Zoom by clicking the Q&A button at the bottom of your screen and then typing your question. Our first question asks, can people feel confident that the COVID-19 vaccines are safe?
Sure. Tom, do you want me to take that one?
Yeah, that'd be great.
Sure. Yes. So, yes, people can be assured that confident that the COVID-19 vaccines are safe. Safety has been a #1 priority in the development and approval of these vaccines, and they have gone through all the same safety tests and meet all the same safety standards as other vaccines. So the U.S. Food and Drug Administration has issued an emergency use authorization for these vaccines, as everyone on this call is aware. And in order for an EUA to be issued, there has to be adequate information on not only safety and effectiveness of the vaccine, but as well as manufacturing quality and consistency, as well as making a determination that the known and potential benefits outweigh the risks of the vaccines. And as Tom alluded to in his talk, there are a whole host of safety monitoring systems in the United States that will be used to rigorously continue to assess the safety of the vaccines.
Thank you very much. Our next question asks, how come there were no cases of severe allergic reactions like anaphylaxis reported in the clinical trials of these vaccines?
I can start on this, and then if Tom has anything to add. So I think there could be a couple of reasons why that is observed. I think one thing to recognize is that in the clinical, the clinical trials were large phase 3 trials, but depending on how rare the rate of anaphylaxis is after these people in the general population, it may be too rare of an outcome to have been observed in the clinical trial. So I think that's one reason. Another reason is that people were not eligible for the clinical trials if they had a previous history of anaphylaxis to a vaccine. So if there are people out there that are more prone to having anaphylaxis to vaccines, they may not have been eligible. And then I think the third potential reason, and again, speculation, is that people who have history of allergic reactions or history of anaphylaxis to other medications or vaccines, they may not be the type of people that are willing to participate in a clinical trial because they have those underlying medical histories. They may have self-selected themselves out of participation. So I think those are a couple potential reasons.
Yeah, this is Tom. I'll just add that, even though there has been quite a bit of awareness about the cases of anaphylaxis that have been reported after vaccination, these are still very rare events. And even in a large clinical trial where 15 or 20,000 individuals are getting vaccinated, that's still a relatively small number of individuals, and to pick up a very rare event like anaphylaxis following immunization.
Thank you very much. A next question asks, what do you mean by immediate allergic reaction?
Sure, I'll take this question. So immediate allergic reaction, we are defining this for the purposes of our guidance. We are defining this as a hypersensitivity type reaction, such as the development of hives or itching or, mouth swelling, facial swelling. So in our guidance, we're calling that, urticardia, flushing, angioedema, anaphylaxis, et cetera. So those types of hypersensitivity type symptoms that develop within 4 hours of a administration of a vaccine or medication. So the goal here is to distinguish those people who are likely to truly be having an allergic reaction following vaccination based on temporal association as well as their signs and symptoms, from those people who might develop a rash for some reason a week later and days later, and really putting those boundaries on the definition so that clinicians who are evaluating patients who come in and say, I developed a rash after vaccination, so that they can really kind of help determine the likelihood that those patients had those signs and symptoms due to an allergic reaction and not something else. So that's the definition that we're using.
Thank you very much. Next question asks, why was the guidance about who should not get the Pfizer or Moderna COVID-19 vaccines changed?
Great question. This is Sarah. I'll answer that one again. So this guidance has been updated primarily because, starting in a few days, people who got their first dose will be eligible to receive their second dose. And we felt that providers really needed more guidance on how to address patients who may have had an allergic reaction after the first dose and how to manage them for the second dose. And I think, we've continued, the reports of anaphylaxis are under investigation, as has been described, but we're continuing to learn more about how frequently this might be happening, et cetera. And so I think we wanted to make sure that we are continuously reevaluating our guidance to make sure it's still, based on the best available evidence. And we felt that this was the right time to do it so that providers had more information once people started coming in for their second dose of vaccine.
Thank you very much. Next question asks, what steps would CDC take if you find a potential safety issue with the vaccines?
Hi, this is Tom. I'll say, if we do detect a potential safety issue, one of the first things we'll start doing is working with partners, to include the Food and Drug Administration and other partners to collaborate and work on rapidly assessing the potential safety issue. There are many safety monitoring systems that CDC and FDA and other partners use. And so we can look in other systems and we can do other methods, and we can also do additional analysis in the system that detected the potential safety problem. We also have groups at CDC that do do reviews of individual cases and do clinical research as well. And then lastly, I'll mention that we would work with our Federal Advisory Committee, the Advisory Committee on Immunization Practices, to present that data, and we would communicate it to the public in a timely and transparent manner.
Thank you very much. How does the risk of severe allergic reaction after getting a Pfizer vaccine versus Moderna vaccine compare to the risk of a severe allergic reaction after other routinely recommended vaccines?
This is Tom. I'll take that question. I think it's early right now. We've only been vaccinating for a few weeks, and we're still in the process of assessing the situation and analyzing the data. I mean, what I can say is, based on the information we have right now, severe allergic reaction after COVID-19 is a rare event, and COVID-19 can be a very serious disease in some segments of the population, and vaccination, I think, is an important tool that we can use to get the pandemic under control. So I think the message is that our safety systems rapidly detected these reports of anaphylaxis, and CDC and FDA are in the process of rapidly assessing this. It is early, and we will continue to communicate with the public and with healthcare providers and keep them informed in a timely manner.
Thank you very much. Next questions. Can you please reiterate who should not get the Pfizer or Moderna vaccines?
Sure, this is Sarah. I can take that one. So the people who should not get either of the COVID-19 vaccines are those people that have had a severe allergic reaction, such as anaphylaxis, after a previous dose of an mRNA COVID-19 vaccine or any of its components. Those people that have had an immediate allergic reaction of any severity to a previous dose of the vaccine or any of its components. And those people who have had an immediate allergic reaction of any severity to polysorbate. And again, polysorbate is not an ingredient in the vaccine, but cross-reactive hypersensitivity between these two, between polysorbate and polyethylene glycol, which is a vaccine component, has been observed. And so until we know more, until the investigations kind of reveal more information, that is also a contraindication to vaccination.
Thank you very much. Next question asks, what can you tell about the safety of vaccinating folks with a prior history of COVID-19 infection with the COVID-19 vaccines?
This is Tom. I can take a crack at that, but I may ask Sarah to step in if she has better information on the clinical trial. So I do not believe that prior history of COVID infection was an exclusion criteria for the clinical trial. So there were individuals who had prior history of infection included in those clinical trials, and they did not observe any safety signals in those individuals.
Yeah, I was going to say essentially the same thing. There was testing done to look for evidence of prior infection in people enrolled in the clinical trials. So there were people in the clinical trials that had evidence that they had a previous infection. And as Tom said, there was no safety concerns identified.
Thank you very much. Our next question asks, what about people with allergies to other things like pets or food? Can they get COVID-19 vaccines?
This is Sarah. I'll take that question. Yes, they can get vaccination. Those people are included in that kind of green box that I showed in my slides of people who can proceed with vaccination. That includes, food, environmental allergies, pet allergies, insect, bee sting allergies, those kinds of things. They can all get the vaccine. They have no precautions or contraindications. The only thing we say about this kind of group of people with those types of allergies is that if they've ever had anaphylaxis due to those pet or food allergies, that they should be observed for 30 minutes instead of 15 minutes.
Thank you very much. And for those looking for those slides and other COCA call materials, we will share the web link where you can find both the slides as well as archive materials towards the end of this call. Our next question asks, what are the possible side effects of these vaccines?
So I can take that one. So I guess in terms of if the question is meant, kind of normal, typical vaccine side effects. For both vaccines, people can have things like a sore arm or redness around the injection site or a little bit of swelling around the injection site. These are pretty common. The majority of people do have those types of symptoms. And they last typically a day or two. So they are pretty minor. For most people, it doesn't really cause any issues at all in terms of being able to do what they need to do during the day and that kind of thing. But some people will have those kind of local symptoms. Some people will also have things like fever or chills or muscle aches or a headache, those kind of systemic symptoms following vaccination. But again, in most people, these are pretty mild. They last a day or two and then go away.
Thank you very much. We have a couple of questions about VAERS. The first question asks, who can report reactions to VAERS and who should report reactions to VAERS?
So this is Tom. So anyone can report a suspected adverse reaction to VAERS. That includes patients, parents, healthcare providers, caregivers. Really, anyone can report a suspected adverse reaction to VAERS. We accept all reports without making any judgments on whether it's biologically plausible if the vaccine could have caused the adverse reaction or whether it's clinically serious. We basically accept reports to VAERS without judging them, and they will get into the database and will get analyzed. We specifically depend on healthcare providers to report to VAERS. We think that healthcare providers are uniquely positioned to support and to help us monitor vaccine safety and have access to information that is going to make the reports both timely and complete. So I think anyone who experiences an adverse event following an immunization should report, even if it's not completely clear if the vaccine caused the adverse event, and that includes all members of the public, but especially healthcare providers who are partners in safety monitoring.
Are there reactions that healthcare providers are required to report to VAERS?
So currently, under the FDA's emergency use authorization, healthcare providers are required to report certain adverse events after COVID-19 vaccination, and under the EUA, those include vaccine administration errors, whether associated with an adverse event or not, severe COVID illness, and that's defined as COVID illness resulting in hospitalization, and then serious adverse events regardless of causality. And these serious adverse events follow the regulatory definition, and that's a death, a life-threatening adverse event, an inpatient hospitalization or prolongation of hospitalization, significant or persistent incapacity, congenital anomaly or birth defect, and also cases of multi-system inflammatory syndrome. In addition to the reporting requirements under the emergency use authorization, CDC encourages healthcare providers to report any clinically significant adverse event following vaccination to VAERS, even if they aren't sure if the vaccination caused the adverse event. And clinically significant is subjective. So, we are relying on healthcare providers to use their clinical judgment on what they think is an important adverse event to report.
Thank you very much. Our next question asks, if I had an allergic reaction to my first dose of COVID-19 vaccine, should I get a different COVID-19 vaccine for my second dose?
This is Sarah. I'll take that question. So if somebody had an allergic reaction to the first dose of one of the mRNA COVID-19 vaccines, either Pfizer or Moderna, we are recommending that they do not get a second dose of either of those two vaccines. I think if additional vaccine products become available in the United States that are different or we don't have the same concerns for, we will have to assess that guidance at a future time. But in terms of the two vaccines that are currently authorized for use in the United States, if you have an allergic reaction to one, we are saying that you should not get a second dose of the other type of vaccine.
Thank you. Our next question asks, which other vaccines include polyethylene glycol or other shared components of the COVID-19 vaccines?
This is Sarah, I'll take that one. So there aren't any other vaccines that contain polyethylene glycol. The other shared components of these two vaccines, there's other lipids, like things like cholesterol, or there's other salts and sugars that I think, are not thought to be a large concern as being, very, for causing allergic reactions. So there are no other vaccines in particular that have PEG.
Thank you very much. We have another question about VAERS. Our inquirer is asking, how do I report to VAERS?
So I had quite a bit of information in my presentation on how to report to VAERS with the links and some instructional material. But VAERS is a fully online electronic reporting process. If you feel like your patient had an adverse event following immunization, you want to report, you simply go to the website, vaers.hhs.gov, and you click on the link to report an adverse event, and it'll take you to an online reporting form, which you can fill in. You have to fill that in at one setting and just hit submit. Or if you can't do it all in one setting, you can download a fillable PDF. You can fill out that PDF and then upload it later at your convenience. But all the reporting is done online on the VAERS website.
Thank you very much. Next questions are, can you please repeat the components of the Pfizer and Moderna COVID-19 vaccines?
Sure. So both vaccines contain mRNA that is, encoding for the spike protein of SARS-CoV-2, and both contain 4 different lipids. So that forms the kind of lipid nanoparticle layer, which kind of helps protect the mRNA from degrading too quickly once it enters the body. And so both contain the 4 different lipids. One of them, as I mentioned before, that is in both vaccines is PEG. And then they do contain some other lipids in common as well. And then the rest of the ingredients are salts, sugars, buffers. There's a table in the guidance where you can kind of see the details. But those are the components, basically mRNA, lipids, salt, sugars, and buffers. Neither of the vaccines contain preservatives or eggs or anything like that.
Thank you very much. And for our audience who are looking for information on things like the components of the vaccines that were shared in a table, as well as the more information on VAERS, we will have that information in the slides that are posted on this COCA Calls webpage, which we'll share the link after this Q&A session. Our next question asks, why is polyethylene glycol a concern in these vaccines?
Sure, I'll take that question. And I just want to preface this by saying that no one really knows if polyethylene glycol is the culprit. It's not been determined. I think everything is still kind of under investigation, but the reason why polyethylene glycol has been kind of singled out, I think, is because most of the other vaccine ingredients are not thought to be of concern. These are things that are in our bodies and, a lot of other things. And so it's the other ingredients, just the plausibility is low that they could be causing something like this. Polyethylene glycol is in a lot of medications. It's not just used in medications or either. It's used for a lot of other purposes. It's thought that severe allergic reactions to polyethylene glycol is rare. There's not that many reported in the literature, but it is something that some experts feel might be under-recognized. So it is a topic of interest, I think, for, that people are looking into more.
Thank you very much. Next question, how long should people wait after getting their COVID-19 vaccine before they leave the location of vaccination?
Sure, I'll take this one. So it really depends on that person's history. I will start by saying that our guidance recommends that all persons have an observation period, regardless of whether that person has any history of allergies or not. So there is an observation period for all people. For people who have had anaphylaxis due to any reason, it is recommended that they wait 30 minutes. For people who are kind of in that precaution category of vaccines, so people who have had an immediate allergic reaction of any severity to a vaccine or injectable therapy, those people are also recommended to be observed for 30 minutes. For all other persons, it's recommended that they have a 15-minute observation period. And we do state in our guidance as well that, if somebody feels that they are developing symptoms of an allergic reaction after they've done their 15 or 30 minutes and they've left, the vaccination site, if they do feel that they are developing signs of an allergic reaction, that they should seek immediate medical care.
Thank you very much. Next question. What are other ways that CDC is monitoring the safety of these COVID-19 vaccines?
Hi, this is Tom again. So I mentioned two systems in my presentation, the Vaccine Adverse Event Reporting System that really anyone can participate in, and then the VSafe program, which is more of a patient-centered system. CDC also has a system called the Vaccine Safety Data Link, which uses electronic health record data and administrative data from large health plans to do surveillance, to do safety monitoring in a covered population of insurers. And this is different than the VAERS in the sense that we have information, near complete information on all individuals as opposed to just partial information on VAERS. And it allows us to assess risk and also to monitor safety in real time, weekly in real time as the data come in. Our colleagues at the Food and Drug Administration also use the Medicare data to do a similar type of analysis where they do real-time analysis, safety monitoring as the data come in, and have additional systems that they work with. And then we have other federal partners that have systems that are spontaneous reporting like VAERS, and also electronic health record-based systems that they do monitoring in. And this is important because if you detect a safety problem in one system, it's often helpful to go and try to validate that in another system. So it's important to have multiple complementary systems that work together that allow us to rapidly detect and assess possible safety problems.
Thank you very much. We have time for one last question, and the question asks, how do I find out what vaccine adverse events have been reported to VAERS?
I think the best way to get information on adverse event reports to VAERS and on vaccine safety in general is to tune in to the Advisory Committee on Immunization Practices meetings when there are safety data presented. The Immunization Safety Office routinely presents safety data at these ACIP meetings in a public forum, and safety is discussed. Specifically for VAERS, there are public data available for VAERS. This is data that is basically stripped of personally identifying information and other information, sensitive information that would allow trace back to an individual patient. And that's available both on the VAERS website in what are research databases, so large Excel or CSV files. And then there's also a search tool on the CDC website called Wonder that allows individuals, anyone can go in there and access the VAERS data through the CDC Wonder platform.
Thank you very much. I want to thank both our presenters today for sharing such critical information with our audience. Today's COCA call will be available on demand a few hours after the live call. You can find the video recording of today's COCA call at emergency.cdc.gov/COCA. Again, that address is emergency.cdc.gov/COCA. COCA call announcements for upcoming COCA calls and other COCA products are available via email. In addition to visiting our webpage, please remember to subscribe to COCA to receive notifications about upcoming COCA calls or other COCA products and services. And be sure to subscribe to receive notifications by going to emergency.cdc.gov/COCA/subscribe.asp. Again, that's emergency.cdc.gov/COCA/subscribe.asp. Please share the call announcements with your clinical colleagues. You can also join the COCA mailing list by visiting the COCA webpage at emergency.cdc.gov/COCA and click on the Get Email Updates link and entering your email address. To stay connected to the latest news from COCA, be sure to like and follow us on Facebook at facebook.com/CDC Clinician Outreach and Communication Activity. Again, thank you for joining us for today's COCA call and have a great day.